My name is Misaki Ishiyama, and I'm a gastroenterology fellow at Showa University Northern Yokohama Hospital in Japan. On behalf of my co-authors, I'd like to thank the editor team of GIE for the opportunity to present our article entitled Impact of the Clinical Use of Artificial Intelligence-Assisted Neoplasia Detection for Colonoscopy. A large-scale prospective propensity score matches study with video. For some background, previous meta-analyses showed that 1/4 of adenomas were overlooked by colonoscopy. Furthermore, approximately 60% of post-colonoscopy colorectal cancer cases are thought to arise from such overlooked lesions. Recent advances in AI technology, especially the emergence of deep learning, have made it possible to use a real-time AI-assisted colorectal polyp detection system in clinical practice. A meta-analysis reported that computer-aided detection, or CADE, significantly increased the ADR. However, the efficacy of a commercially available CADE system in actual clinical practice is still unclear. So, we conducted a prospective study to elucidate the efficacy of a regulatory approved CADE system named END-BRAIN-I in a large-scale study with a high number of patients and endoscopists. During the study period, 2,261 patients underwent colonoscopy, and 172 patients were excluded in accordance with the exclusion criteria. Propensity score matching was conducted using 5 factors: indication, age, sex, body preparation, endoscopist expertise, resulting in 1,836 patients being included in the analysis. 9 non-expert endoscopists and 21 expert endoscopists participated in this study. The ADR was significantly higher in the CADE group than in the control group without extending the withdrawal time. There was no significant increase in the detection rate of advanced neoplasia. This result indicates that a simple CADE system might not increase the large adenoma detection rate because it cannot detect lesions located in blind spots. A combination of CADE systems and real-time blind spot monitoring technology might improve the quality of colonoscopy. This study had advantages compared with previous similar studies. The number of patients who we enrolled and the number of endoscopists who involved in this study were higher compared with previous studies. These strengths indicate that the results of this study are robust regardless of the endoscopist performances. However, we cannot eliminate potential selection bias and inventor bias. To overcome these limitations, a multi-center randomized study is needed to elucidate the efficacy of this CADE system in different environments. Thank you very much for your kind attention.